You can start the recording as well.
And I'll just, before I disconnect, I'll just make you the host sketch, but after I start the webinar.
Okay.
So, all right, now we're live.
Fantastic.
Доброго дня, шановні колеги. Ви зараз підключаєтесь.
Good afternoon, dear colleagues. Now you are joining our lecture on catheter-associated bloodstream infections prevention. This is the Public Health Center. We're expecting other colleagues to join us, and then we will start. So we can see that there are about 300 participants online.
Can we already start?
Maybe 1 minute.
Як я бачу, кількість слухачів в нас вже
As far as I can see, the number of participants is more or less stable, so we will probably start. Hello again. You're at the UPHC webinar. This is a series of lectures, European experience in implementation of IPC and antimicrobial stewardship in Ukraine. This is the continuation of the series of the webinars organized under support of our partners and colleagues from CDC, US CDC, ICAP, Columbia University, and the speakers and lecturers, experts in infection control from the European Committee on Infection Control. So our today's lecture will be about the prevention of catheter-associated bloodstream infections and the maintenance of catheters, care of catheters. Our today's speaker is an experienced expert, Jesus Rodriguez Baño. He is the professor of medicine in the University of Sevilla, head of the Department for Infectious Diseases in the University Clinic in Virgen Macarena, who will share his very profound and important for us experience. Let me remind all the participants that we have the simultaneous interpretation option today, so while you're having time, please use it. Those who are regular visitors, they know how to do that. For the newcomers, let me remind you that during today's meeting, you need to press the globe-shaped button and select Ukrainian channel. And in that case, you'll be able to hear the interpretation. In the end of the lecture, you will be able to ask your questions in the chat box, the questions to Professor Baño. In the end, after the presentation, we're going to have a Q&A session. So please stay till the end. And I also would like to know that our series of lectures will continue till August. So please follow the announcements of the UPHC about further lectures. So we are about to start, and let me give the floor to Professor Jesus.
Thank you very much, Nihat, and thank you very much to all colleagues organizing this activity. It's a really big pleasure and honor to participate in this webinar. And thank you to the UK colleagues as well for letting me to participate. All my support to the Ukrainian people in the difficult times that you are living. Well, our task today, if you go to the next slide, is to discuss about prevention of catheter-associated bloodstream infections. And also we'll provide some information about catheter care and analysis of data on the prevalence of device-associated infections. Next slide, please. Next slide. I do not have any conflict of interest. Next slide. So our first issue is to discuss and to have a clear information about what type of catheters we are considering. The risk of infection in the different catheters is different depending on different variables. But one of the variables is the type of catheter that we are discussing. So we may have a peripheral catheter, which is inserted typically in one of the arms in adult patients. We can have what we call midline catheters that are also inserted in the arms, but the catheter is longer and have a trajectory inside the vein that is much longer than typical peripheral catheters. We have what we call peripheral inserted central catheters, which are catheters that reaches a central vein by the subclavian or cavus venous, but are inserted also in the peripheral vein. And we have the typical central venous catheter that are usually inserted in the subclavian vein or the jugular vein or sometimes the femoral veins. Also, we have implanted catheters or catheters which may have a subcutaneous part and catheters that are implanted as a port in which you can use by puncturing the port to administer medication. So the risk of infection is different for all these kinds of catheters, and we need to probably address some specific preventive measures for a specific type of catheters. Next slide, please. If we consider the concept of vascular catheter-related infection, we need to differentiate what we call an insertion site infection, which typically diagnosed by looking at the insertion site, and we can see redness or even some exudate, purulent exudate coming out from the insertion site. The differential diagnosis for this is a chemical, in peripheral catheter, mostly it's a peripheral, it's a chemical phlebitis that can be caused by different type of drugs that are administered through the peripheral catheters and that cause inflammation of the vein without infection. Then in catheters which has a subcutaneous tunnel, in implanted catheter, we can have what we call a tunnelitis or a subcutaneous tunnel infection. But what we're dealing mostly today is what we call a catheter-associated bloodstream infection. You will always see in the literature the term CLABSI, which relates to central line associated bloodstream infection, which of course is related to bloodstream infection that are associated only with central venous catheter, but not with peripheral catheters. And here we have a specific point that I would like to address is that this is the typical type of infection that are included in the most surveillance systems. And this is excluding other types of infection or bloodstream infection associated with other types of catheter that can also be important. Next slide. Next slide. So first point to discuss is how important is it to discuss and to take care about catheter-associated bloodstream infection or bacteremia. Well, obviously this is a very important healthcare problem. First, because it is frequent. The typical rates that are reported in the literature or in surveillance samples includes from 0.5 to 5 cases per 1,000 days of use of central venous catheter in patients admitted to the ICUs. So that some calculation that have been done in the United States suggests that around 80,000 cases may be occurring per year in the ICUs, and if we include patients outside the ICUs, that would include almost 250,000 cases per year. So that's enormous amount of infections. So probably in the European community, we can have probably similar number of cases per year. And as I said, the rate is not well known outside the ICU and not well known when we're not considering central venous catheter, because surveillance is mostly centered in ICU patients and in central venous catheter. Probably some of this infection can be underestimated. But it's not only the issue that it's frequent, it's also important that they are associated with increased hospital stay, increased mortality. You know that a bloodstream infection is associated with, depending on the severity of the patient, depending on several of the features, the bacteria, etc., could be from 5 to 30% mortality of bloodstream infections. And it's associated, of course, with very high costs when we need to treat this infection. Next slide, please. So if we consider, for example, this study in which systematic review on short-term peripheral venous catheter bloodstream infections are considered, and we need to consider that peripheral catheter are the most frequently used in most hospitals, you can see that these catheters account for a mean of 6.3 to 23% of nosocomial protein infections. So that means that these infections are really frequent and are underestimated in most surveillance systems. And of course, it can be very variable depending on the type of patient, depending on the hospital. But these figures means that we are dealing with an underestimated problem that can be quite relevant. Next slide. And because I work in infection control, I'm a clinician, I would like just to exemplify the importance of these infections with a clinical case. This is a 58 years old male that was admitted because of a pneumococcal pneumonia to the hospital. And on day 6, the patient developed what was considered potential chemical phlebitis in the peripheral catheter, but the blood cultures grow Staphylococcus aureus, which makes it susceptible. So we have a bloodstream infection associated with an infection of the peripheral catheter only 6 days after admission. So the patient who were almost able to go at home by the next day had to stay in the hospital, and the patient developed persistent bacteremia, despite treatment has been early with high dose cloxacillin, and the catheter was removed by the next day. And finally, the patient was diagnosed with an aortic valve endocarditis and needed a valve replacement. So please consider this as potentially very serious infections causing very serious complications and even relevant mortality. Next slide. So as I explained the data on device-associated hospital-acquired infection in general, not only regarding catheter, but in general, as you know, for doing the surveillance, we need to define a site, like a specific hospital or a specific ward in the hospital and a specific time period, or do continuous surveillance. Then we define the event that will be the numerator for our indicator, and typically will be the device-associated infection that we are conducting surveillance with. Could be catheter-related infection, could be a ventilator-associated pneumonia, could be any other type of infection associated, or urinary tract infection associated with urinary catheters. Then we have to implement a system to detect those infections. And typically we will need to report information from the microbiology laboratory, but also from clinical surveillance of potential cases. Then we need to define the denominator. The denominator will be the population at risk if we are doing incidence. But if we are trying to provide data of incidence density, we will be measuring the time at risk, which is the summatory of all the times, for the days that all exposed patients to that device can be added during the period of time that we are doing the surveillance. So if a patient have a catheter 1 day, will sum 1 day. If a patient have a catheter for 30 days, will sum 30 days to that denominator. So we are summing days and not patients. And each patient is providing the number of days that is exposed to the device for the denominator. If possible, we can try to implement a system to count those denominators. So you can, if you have access to some automatic system to detect those, you can use them. But if not, you can use just counting every day the number of patients with the device, and then at the very end, submit the number of patient days for all of individual days that you're doing this. If possible and available, you can try to do a risk stratification for the patients, not frequently done for catheter, but could be done for other type of infections. But also it's important, as I will comment later, that we also try to measure not only the number of infections per time at risk, but also the use of the device. Because if you are reducing the number of catheters, you will be reducing the denominator, and you may not see a decrease in the incidence of infection while you are reducing the absolute number of infections. So you also need to measure how many catheters and how many days of catheters you are using in that ward or in that hospital over time. Next slide, please. So dealing with catheter-associated bloodstream infection, the numerator is typically that, the bacteremia that has with catheter, and the denominator will be typically in ICU 1,000 catheter days, and outside the ICU, if that's not feasible to be contemplated, like the total number of patient days. But you have to consider that there is a huge variability in catheter use in different wards in the hospital or in different type of hospitals. So you need to be aware of that. And this type of indicators will not be very much suitable for benchmarking unless you have very similar wards or hospital to be compared. Next slide. So typically, surveillance in the ICU includes the incidence density of central line associated bloodstream infection, this CLABSI that I commented before. The numerator will be the associated bloodstream infections to catheters, central catheters. You will capture those from microbiology, from the blood cultures that are positive in microbiology, and looking if they have the criteria for catheter-related infection. You need to be aware that blood cultures may not be done as frequently as advisable. And in that case, you may be underestimating your rate because you are not doing enough blood cultures in that situation. So you need to be careful about that. Also, you need to be careful about contamination if blood cultures are taken through the catheters only and not as recommended, that they should be taken from peripheral veins or both from a peripheral vein and through the catheter. And the denominator, as I explained, will be the days that the patient have a central catheter. Next slide. In other words, the denominator will be similar, but we will be included possibly other type of catheter. We can be included peripheral to central catheter, we call PICS, or midline catheters, or even peripheral catheters. And as I said, if we cannot count for the denominator, the catheter days, we should measure patient days with the limitation that I explained before. Next slide. So for your numerator, particularly when you're dealing with CLABSIs, you need to use standard definition that is used in most of the surveillance system. This is the definition by the CDC, the American CDC, which is reasonable. And as you can see, there are three criteria. One is that a clinical site of infection, so the patients have fever or some other criteria for sepsis. The second is that there is a bloodstream infection, but there's no other clear alternate source for the bloodstream infection. So if the patient have a pneumonia or have an intra-abdominal infection, and the pathogen is a typical pathogen causing those type of infection, you will probably think that the source of this bloodstream infection is not the catheter, but is other type of infection. And then you have a positive blood culture obtained from a peripheral vein, not through the catheter, with any of these other microbiological features. One is that the catheter has been removed and sent to culture, and then the culture of the catheter tip is positive for the same microorganism. Second is that there is a higher number of organisms growing from the catheter. That if you obtain your sample, your blood sample from the catheter and from the peripheral vein, you have a higher count of bacteria in the sample obtained from the catheter. Quantitative cultures are not performed in any hospital that I know, so we also use the other criteria, which is the time that the blood takes to grow. So when the blood culture is positive, it should be earlier positive in the catheter obtained by the catheter, meaning that this sample has a higher bacterial count than the sample obtained from the peripheral vein. And the typical threshold for that is 2 hours difference. So the catheter obtained from the catheter is positive 2 hours before the catheter obtained by a peripheral vein, you have to be aware that the amount of blood, the volume of blood taken from both the catheter and blood the peripheral vein should be similar, because if you have a higher amount of blood, you will have an earlier growth in one of those. And also both of them should be included at the same time in the machine if you have an automatic machine providing continuous growth of the bacteria. So this is the criteria that is frequently used for catheters that you are not removing, but if you remove the catheter, the criteria typically is a positive culture of the catheter tip. One problem here is that peripheral catheters, when removed, are frequently not sent to culture. And also there's a recommendation not to send them routinely to culture. So if you do a blood culture and you have a high suspicion that is the catheter, it's okay to send them for culture to the micro lab, but otherwise you will not be sending that, and you need to be aware whether you have signs in the site of insertion, signs of infection in the site of. Next slide, please. So this is the definition by the Australian recommendations, are a little bit different because they just include the possibility the patient have to have a catheter in place, a central catheter in place, and they don't require the macrobiological techniques like having a positive tip culture or a positive differential time in the blood culture obtained through peripheral vein and the catheter. They just require that you have excluded other potential sources of infection. Next slide. But also, if you can perform these microbiological criteria, these also are considerations in this Australian criteria. So you need to agree on what criteria you're going to use, and then apply those criteria consistently and continuously in your patients. Next slide. In this slide, what I would like to show is that what is the workflow that you should go in order to understand that a case is a CLABSI. So first you have a positive blood culture, then you look at the criteria whether there is another source of infection or not. If there's another clear source of infection, you will not consider this as a CLABSI. If yes, then you will consider whether there's a barrier injury with having a catheter. This is a criteria that will be met. And then if the blood culture was taken when a patient has a catheter, and then if all those criteria are consistent, then you will declare this as a catheter-related bacteria. So important here is that you go from microbiology lab back to your patient and see whether the patient fulfills the criteria for CLABSI. In some of the patients, you will not have a definite criteria. You will need to take a decision based on the criteria that you have agreed for those, let's say, doubtful patients. That sometimes you will not have a definite criteria, but you can have a possible or probable criteria, and you need to agree and to be consistent across time to use exactly the same criteria to avoid biases in the quantification of your cases. Next slide, please. Well, a word on automatic and semi-automatic surveillance that are being considered in different hospitals in the world. Automatic surveillance means that the machines that all the work, so your IT people prepare a way to detect all your potential cases for catheter-related infections. So you capture the microbiological lab, then you capture whether the patient have a central venous catheter, you capture whether in the chart the medical doctor writes something about the potential source of infection, etc., 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 and the machine decides whether it is a CLABSI or not. Most of hospitals are not moving to fully automatic system, but to semi-automatic system, which means that what the machine helps you to do is to select the patient who probably may have a catheter-related infection and forget about the others. So if you have a positive blood culture, there are some criteria that would suggest you to look for that specific patient For example, you will be excluding patients who do not have a catheter in the 3 days before, or you will be excluding patients in which evidence source is in the system. And those cases were probably because of your criteria may have a catheter infection that the surveillance system, the IPC nurses or the IPC doctor should go to see those specific patients and mark them as a case. So you're reducing the number of patients that you are following and maybe saving some time if these systems are available. You need to, if you try to work on that, you need to be careful about the criteria that other hospitals apply, because they may not be applicable to your hospital, because the criteria for selecting the patient may not be easy to detect for your computer systems, or your computer system may be different, etc. So you need to be sure that the system that you are using for a semi-automatic surveillance is applicable in your hospital. Next slide. And of course, when dealing with this, we need to tailor and balance to what extent we are saving time and to what extent we are not only doing surveillance, but by being present in the wards doing the surveillance, we can also be at the same time doing intervention that can improve management of catheters. So if you are there in the ICU and you are working with your colleagues and they say to do the surveillance, you are there and you can see whether there are areas of improvement in the management of catheters. If you collect all the data from an office outside the ICU, you are not there, and therefore maybe the impact that you as an infection prevention doctor or nurse are doing is much lower. So you need to tailor and balance the importance of having surveillance data, but the importance also of being there to discuss with our colleagues and try to improve. Well, when we're dealing about prevention, to say you went back to the slide, you need to move forward to the next slide. Next one. That's it. Thank you. So there are several documents that can help you with or guidelines or guidance document with recommendations about preventing catheter infection. These are the ones that were developed by the American CDC and the SHEAR, IDSA, and APIC in the United States. There's a document from 2011 and let's say an update in 2022. You can see the ECDC, the European CDC resources directory that you can consult, where you can have a look at all the guidelines. And only 5 days ago, the WHO published also a guideline for the care of peripherally inserted vascular catheter, both PICCs and peripheral catheters. I could not include those in that presentation because I had to send my presentation before that for translation, but I have reviewed the document and I think that the main points in the document are considered in my presentation. But please have a look at those guidelines published by WHO. Easily accessible, and if you have any problem with that, please, I'm happy to discuss that with you anytime or by email. Or next slide, please. So very importantly for prevention actions, you need to consider where are you, what is the scenario that you are working in. It depends on the wards. It's not the same an ICU. It's not the same an ICU with which type of patient do you have in your ICU? Post-surgical patients are mostly respiratory patients. What type of ICU are you working in? In ICU, typically, most of the patients will have midlines or PICCs or even central venous catheters. Sometimes you have patients with arterial catheters, and you will have a good number of patients with renal replacement techniques, and even you may have patients in ECMO. It is different to patients in regular wards, where you also may have patients with different type of catheters, just depending on the type of ward. But CVC are less frequent than in the ECU typically. And then in outpatients, you also have to consider activities in outpatients. In outpatients, you typically will have tunnel catheter for patients who are receiving chemotherapy, or midline catheter for patients receiving chemotherapy, and some ports, depending on the practice in your hospital. But typically oncological patients or hemodialysis patient who needs a catheter have a tunnel catheter or a midline, and some oncological patient have a portal. As I said, a hemodialysis patient will usually have a tunnel catheter. Patients needing home total parenteral nutrition because of digestive tract problems will typically have also midlines or tunnel catheters, and oncomyological patients will typically have those catheters also for chemotherapy. So you need to see where you're working and see what actions you need to develop in the different type of scenarios. Right? There is a nice review. I think we should go to the next slide, please. Yes, thank you very much. This is a nice review published in New England Journal of Medicine last year, mostly related to central venous catheter bloodstream infection. And here you can see the pathogenesis of these infections and the roots that leads the bacteria to the bloodstream. So typically what you have in here, as you can see, is that in point 1, you can have a contamination at the site where the catheter has been implanted. So the skin contamination outside the catheter can grow through an extraluminal surface of the catheter and travels through the extraluminal surface of the catheter until the tip of the catheter and then the blood. This is what we call the extraluminal source of infection. In point 2, you can see that catheters can be contaminated in their head when you need to disconnect the head to change the line, to change the system, or to administer a specific drug or something like that. You will be contaminating the head, and therefore, via the intraluminal surface of the catheter, the bacteria can also travel until the bloodstream, and of course, it will be pushed by the fluids that you are mixing through the catheters. And finally, well, you can also have what we call a hematogenous infection of the catheter. The patient may have an infection at a distant site. There are bacteria in the blood, and these bacteria may colonize the surface of the catheter. And because in a secondary catheter infection from a distant site, and those mostly are associated with Staph aureus, with Candida, and some other bacteria that can adhere very frequently to the catheters. And the number 4, a final way of having a bloodstream infection related to a catheter is when we infuse a fluid that is already contaminated. So we're providing a contaminated fluid. This is not that rare because and many outbreaks of this type of infection have been communicated when some fluids are used in different patients, which is not recommended nowadays because of that, can be contaminated. So we need to be aware of that. Next slide, please. So for the prevention, the 4 big topics are first, to avoid or reduce the use of catheters that are not needed. The second is how do we insert a catheter trying to prevent infection. The third is how to care a catheter that is implanted. The 4th is whatever the measures of the activities that we developed before, how do we implement them so that they are really done by our colleagues. Next slide. So let's go through this point. The first is avoiding unneeded catheters. So first, do not insert or maintain a catheter just in case, unless it's clearly justified. So the very first minute that you can remove a catheter, please do. This is something we need to teach our colleagues to do, not leave a catheter there just because tomorrow or this afternoon it might be needed. We need to change all treatment to oral therapy as soon as possible, and do whatever action we can do to remove all catheters when they are not needed. There are this is a systematic review for the interventions of reducing the unnecessary, in this case, central venous catheter. And the conclusion is that reducing the number of days that a catheter is in place because it's not needed reduce significantly the rate of bacteremia associated with that catheter. And it's also for peripheral catheters, of course. And this is very much underestimated. So this is a very important issue too. Next slide, please. What about the when we're doing this, you need to be careful because you are reducing the denominator of your indicator, of your incidence, because you're reducing the number of days that catheter are placed in the patient. So if you do that in your ICU and you measure number of episodes per 1,000 patient catheter days, then you will be reducing the denominator. And then your indicator may not change even if you are reducing the absolute number of collapses. So you need to also measure the number of days that you have catheters in your unit or in your ward or in your hospital as much as possible. Next slide. Second point is the catheter insection. So these are the recommendations summarized in a review by Betty and colleagues in published Infection Control and Epidemiology in 2022. And you can see that well, there are some basic recommendations. You know that the basic recommendation is please use a process so that everybody knows that there are several steps that you need to go through when you're inserting a central venous catheter, and if possible, use a checklist so that you are sure that you are following the process. Of course, hand hygiene previous to the catheter insertion manipulation is critical. Try to use subclavian vein if possible because it's the one with the lower rate of infection. Use an all-inclusive cart or kit so that you do not need to be touching different parts of the catheter insertion kit. So if you have everything in one box that you can open, that is sterile, and you can open with a sterile technique, everything will be there. You don't need to be manipulating or touching things outside that. If you can use a ultrasound guidance if possible, it's not available everywhere. For central venous catheter, there is a moderate quality of evidence enough to recommend maximum sterile barrier precautions. Please use a gown, sterile gloves, use a mask to catheterize a central venous catheter. This is an important recommendation. And use alcoholic chlorhexidine antiseptic for skin preparation, which is the one associated even in some trials with the lowest rate of infection. Next slide. So this is well, let's say, established for central venous catheter, but what about peripheral catheters? So this is very well explained in the WHO recent recommendations that were published 5 years ago. So please have a look at that document if you can. But important is that skin preparation should be also using alcohol and disinfectant with residual effects, or chlorhexidine will do. Select the appropriate catheter insertion site. Have all the insertions set also in one box, and use an aseptic technique. The recommended aseptic technique is a non-touch aseptic technique. So you can use non-sterile glove, one-use non-sterile glove, but if you use non-sterile glove, you should use a non-touching technique. You should not be touching the vein to do the catheter. You can touch the vein before you disinfect the skin with your alcohol, your disinfectant, but once you've done the disinfection, do not touch the skin of the patient. So using a non-touch the skin is better. Next slide, please. This is a study that compared chlorhexidine plus alcohol versus povidone iodine plus alcohol, and also the issue of innovative devices to prevent peripheral venous catheter infection or failures. And you can see here that chlorhexidine plus alcohol was associated or caused a lower rate of failure and infections compared to povidone iodine plus alcohol. So because of that, there is a good level recommendation to use whenever possible chlorhexidine with alcohol. Next slide, please. In this study, the patients with midline catheters and peripherally inserted central catheter were compared. This is a observational study, it's not a randomized trial. That in this study, the authors, well, this is a reasonably well-performed observational studies where confounding were reasonably well controlled. And these colleagues concluded that midlines were associated with lower risk of pleural infections and occlusion compared to peripherally inserted central catheters. That means that midline catheters are probably standard or should be considered standard of care for patients needed more than 7 days of IV drugs, and should be or should try to be implemented as in our hospital in the moment that we think that this patient is going to need a prolonged period of time with intravenous treatment. It's better that than to be changing or having the risk of having repeated phlebitis or infection in peripheral catheters. But instead of inserting a PIC, having a midline catheter seems to be a good option. Next slide. What about once we have a catheter in place, what is the care of the catheter? So again, here you can have a summary of the recommendations. So for central venous catheter, you should have enough nurses to take adequate care of the catheters. That's a critical aspect. In some of our hospitals, when we have shortage of nurses, we're also worried about that. So this is an important point to consider, the nurse-to-patient ratio. We should use dressings for the catheters, and ideally, when the catheter is going to be there for a prolonged period of time, you should use dressings that have chlorhexidine. For tunnel catheters, having a transparent dressing is useful so that you can see the tunnel, but also in central venous catheter, it's useful to have transparent dressing so that you can see the insertion site without needing to remove the dressing, and then therefore you're reducing the manipulation of the site. If you don't have, because they are more expensive, transparent one, then you should use appropriate sterile dressing, and therefore you will need to be touching with sterile gloves over it to see whether there is any tenderness around the catheter, and after 48, 72 hours, you should have a look at the insertion site by moving the dressing. When you are using the catheter halves, because you need to change all the tubes, or you're administering a new drug through the catheter, you need to disinfect the catheter half or the needless connections before their use, and using an antiseptic technique to access the catheter is mandatory here. And as I said, remove non-necessary catheters. And regarding removing or routine replacement of catheter, there is no evidence that you need to remove your central venous catheter in any periodic period of time. You can leave them until indicated. But it's important that the administration said when used for blood products or lipid formulations, you should replace them in intervals of 7 days, because these sets are more frequently contaminated and then can cause an infection. Next slide. What about the care of peripheral catheters? Well, hand hygiene before and after catheter manipulations, as before, is mandatory, of course. There is some doubt about whether you should disinfect the halves before accessing the catheter. In this review here by Walter Thing, other colleagues, they recommend it. The WHO document do not provide a specific recommendation for that. You can use non-sterile gloves that use a non-touching techniques for the hab, so do not touch the hab. It's very important. Yes, outside the connection, you can manipulate the connection outside the hab to avoid touching the hab. As I said, you should visually or by palpation know how the insertion site is periodically. You can do that every other day or every 72 hours if there is not any sign of like dressing that is not inadequately adhered. You don't need to replace peripheral catheter periodically. There's a Cochrane review that found no benefit of doing an automatic or periodic replacement of peripheral catheters, but it doesn't mean that you cannot do that. The WHO document says that there's no benefit of one over the other. So if a peripheral catheter has been inserted in the emergency condition, you can consider replacing it. After that, you should replace it afterwards. But in other case, you may just change it when it clinically indicated. Next slide, please. Well, the final point is about implementation. So you all know these seminal papers published in New England Journal of Medicine 2016 with the bundle of activities that were championed by a person in the ICU and with a checklist, were very effective in reducing the rate of eclampsia. And what is important here is to avoid the gap between what we know that had to be done and whether we do it or not, by making our protocol simple, traceable, and doable. This is absolutely next slide. So implementing a bundle of actions is a very good way to do it. It's recommended. So choose a champion in the world where you're working, someone local that really will take this as one of the tasks. Select a few critical measures that should be done because they are very well evidence-based. Implement a checklist so that we can measure adherence to these very few critical measures and provide feedback to our healthcare workers about how they're doing and what the rest do with. Next slide, please. This is just a summary of some general measures for implementation that you need to address. So all what we discussed previously about the measure for insertion, for care, can be converted to specific actions in the bundle. So I will not go into all of these because you know them, but just remember that the idea is to convert those measures into specific bundles in your hospital. Next slide. You can have a specific checklist that can be more or less complex depending on your resources, on your problems, etc. So this is something that you need to implement in your hospital and use whatever is out there to see how it works in your hospital. So it's not automatically that you can use this CDC checklist, for example. You may simplify it, you may add something that you think is important because if you have problems with that. So applicability of anything that you find out there is very important. Next slide. And just to finalize, this is my summary of management. So diagnosis, important to do blood cultures. If the catheter is kept, do extraction of blood from the catheter from the peripheral vein to measure the time growth. If you're sending the tip of culture, which is not done routinely for peripherals, send them all with the blood cultures to have both the blood cultures and the tip culture. And if you have exudate and the sensor site, I can comment that, but of course you can take a sample from that exudate and culture. Remove every single catheter that you can replace or is not needed. So this is the first rule. Just for treatment, some information about empirical drug. Typically you will be using a anti-gram positive drug, but you can consider adding an anti-gram negative if the catheter has been in place for more than 7-10 days, because gram negatives are more frequent as the catheter is in place more days. Change to target treatment as soon as you have the isolate and the stability testing. And for implanted catheters you would like to keep, and if you have a low risk pathogen like coagulase negative staphylococci, you may try to keep the catheter by doing systemic and lock-in therapy. It's a therapy that you provide inside the catheter, and you seal the catheter with that lock-in therapy, and with that you can avoid removing some catheters that are very problematic to replace because they are being implanted surgically or the patient is very high risk. You cannot do that when the patient is septic. You cannot do that when it's a high risk bacteria like Candida or Staph aureus, but you can do that for coagulase negative staphylococci in some cases. And I think that's all. Next slide. Thank you very much for your attention. Again, a big pleasure to participate, and I'm open for your potential questions. Thank you very much.
Дуже дякую, професоре Родрігес. Дуже цікаво.
Thank you very much, Professor. A very interesting and informative lecture. Thank you very much for joining us and providing this very interesting material. Let me have a look in the chat. So many colleagues say that thank you. And I would like also to thank you and ICAP CDC for organizing this very important and informative lectures. We have several questions in the chat, and now we will read them. So let me just find it. There's a question: who is supposed to fill in the information about catheter installation, and where this information should be written to?
So if you're, thank you for the question. If you're talking about surveillance, there are mostly two ways to address surveillance. One is you can have an external team doing the surveillance to whatever the ward you're working with. So there will be an external person, typically infection control nurse. So you can go to the SAU, you can have the number of beds that you have in the SAU, you have a look around and see how many patients have a catheter. So if today you have 7 patients with a catheter, you have 7, then tomorrow you have 10, then it's 10 plus 7 is 17. And therefore, across the month, you can have the number of days of catheter by just counting daily how many patients you have there. So with that, you have the denominator. And then it typically is done by the infection control nurse. And then for the numerators, the infection control nurse should be reported that a patient have a bloodstream infection in that ward by the microbiology laboratory. In our hospital, for example, this is done by the doctor who takes care of bloodstream infection. And when there is an infection that this doctor considered because of the criteria that is catheter related, he or she reports to the infection control nurse. So the infection control nurse have 1 point for the numerator. This can only be done inside. It can only be done by people working in the same ward, by the ICU people, or whatever the ward you're doing the surveillance. So but in that case, you should have one champion, one person taking care of the denominators and the numerators and having that information recorded from the microbiology lab to discuss whether this patient is or not a case of CLABSI.
Дуже дякую за надану відповідь.
Thank you very much for your answer. There's another practical question. What frequency of change in peripheral catheter would you recommend? How often?
Of
should we
changing what, sorry?
Peripheral catheter.
All right. So
PVC.
we've been in our hospital discussing that for years, because anytime that we see a bacteremia, particularly due to Staph aureus associated with a peripheral catheter, is a pain. I mean, it's terrible. And we always think that if this catheter has been removed or changed before, we probably have avoided it. But the reality is when you look at the studies that have been performed, and there, as I said, there's a Cochrane review that looked at all the relevant studies that were done, there is not a clear benefit for doing a systematic change in peripheral catheters in a specific period of time. Well, it probably because some of the catheters can stay without complications and so on. Maybe the patient were colonized high risk, but we don't detect, don't do surveillance for Staph aureus colonization to all patients admitted in the hospital. So it's complex. I would say that the general recommendation is there is no evidence that you need to change the peripheral catheters in a specific period of time. By my personal view, and this is very, very personal view, is that first, if you think that your patient is going to need a prolonged time of intravenous treatment, try to go for a midline catheter from the very beginning. If you insert them and take care of them, they are safer. And second, if not, if you're having peripheral catheter, I prefer the catheter to be changed every 3-4 days maximum. 5 if the catheter is doing very well and you're having no problem. But I prefer, I would say, because any case of Staph aureus bacteremia for me is open. But it's a personal opinion more than an evidence-based opinion.
Дуже дякую за відповідь.
Thank you very much for your answer. The next question is related to the following. if a child has a history of catheter-associated bloodstream infection, is there any kind of protection for such child and kind of impregnation?
Well, I don't know if you mean about catheter impregnate with antibiotics or with metals to prevent infections. So these catheters are more expensive. There is some recommendations in high-income countries to use this type of catheters in high-risk patients or in circumstances where the catheter is going to be probably used for a prolonged period of time, at least in those patients, but they are most costly. And if you do all other measures to avoid infections, the benefit of those catheters is very much reduced. What I mean is that I will not implement these catheters if you are not doing all other measures that you need to implement, and people is not adherent to the basic measures. If healthcare workers are adherent to baseline measure and you have resources to do that, then you can consider implementing them, particularly, as you said, for some high-risk children or some high-risk adults in specific circumstances.
Дуже дякую, професоре. Тут ще уточнюють в чаті.
Thank you, Professor. And also, people write in the chat that they meant silver impregnation.
Okay. Yes. Well, silver is also associated with lower rates of infections in some studies. Silver catheters, they seems to be safe. They are probably associated with less problem of antibiotic resistance. So I think they are useful. But as I said, I will not use them if you are not sure that you have implemented a good bundle to avoid infections with the baseline measures. So it could be an additional measures to a high rate of basic adherence to general measures.
Повністю погоджуюся з вами.
I fully agree with you. Thank you. And regarding the next question, maybe you have some recommendations, or from your experience, what is the optimal number of patients per nurse, depending on the ward?
Well, this is a important questions and a very old struggle issue that we need to discuss with our manager. There are some recommendations for ICU patients, but it also depends on the type of ICU. The ICUs are quite heterogeneous, and you can have ICUs with high demanding patients for care, and other ICUs with lower care demand. So it also may depend on the type of ICU. It's not the same patient where you're taking care of coronary care patients, respiratory tract problem patients, or surgical patients. So you need to be aware of that. But in ICU, typically, the recommendations are 1 nurse per 2 or maximum 3 beds. That's the maximum. If you have additional problems, like patient, for example, we have a patient with ECMO, well, that may require even 1 nurse per patient specifically. So it depends on which type of patient and what type of requirement you have. We try to have 1 nurse per 2 beds in ICUs with high demands of care, and I can tell you that we don't get that in some periods of the year, but this will be the general recommendation.
Дуже дякую за відповідь. Ще таке запитання.
Thank you very much. There's another question. People are asking, what recommendations do you have with regard to blood sampling from the catheter and how to avoid contamination? And what is the best way to differentiate BSI from sepsis?
For the first question, well, we should try to train our nurses not to get blood cultures from the catheters, never, unless you want to diagnose a catheter-related infection in a catheter that you are not removing, or at least you are not removing in that moment. This is the only exception in which you should have a blood, an extraction of blood from a peripheral vein and at the same time or very, very near from the catheter or from all the lumens of the catheter. And then you need to label them very clearly. This sample was taken from the catheter, this sample was taken from the peripheral vein, send them together to the lab and should be put together in the machine, both of them, and have the same volume in both blood culture bottles. So if you do that, you can reasonably be sure that if you have a 2 hours difference in the growth from the catheter with respect to the peripheral, it's very indicative of having a bloodstream infection from the catheter. In other circumstances, we need to tell our nurses, do not take blood samples for blood culture from the catheters, because catheters are frequently contaminated, but it doesn't mean that you have a bloodstream infection due to the catheter. So this is really important. The second point was to differentiate BSI bloodstream infection from sepsis. So if we use the sepsis criteria 2016 consensus document for diagnosing sepsis, you mean that the patient had a dysregulated response to infection. That means that the patient should have something that is not normal when you have an infection. When you have an infection, you have fever, that's normal. You have leukocytosis, that's normal. You don't feel well, that's normal. But if you have failure in your critical organs, more than one, then you have sepsis. Then you should use the SOFA criteria, and you have 2 points or more for the SOFA criteria to say that you have some response that is not regulated, that is regulated, that is providing harm to you. And therefore, we try to use the SOFA criteria to differentiate infection that can be even a bloodstream infection, but the response of the person is adequate from a dysregulated response.
Дуже дякую за вичерпну відповідь, професоре.
Thank you very much. And I would like just to tell to all the participants, we are already out of time. And let's have the final question and we will finish this question. The last question is interesting. What microflora was isolated from the patient with pneumonia from your presentation? And what drawbacks in terms of catheter care were identified during the investigation?
Are you referring to the clinical case that I'm not sure if I understand that well. Just an example. This patient did not have a pneumonia. You mean the pneumonia? The patient was admitted with a pneumococcal pneumonia. So the patient we've been treating with ampicillin, intravenous ampicillin. Ampicillin is we provide them every 6 hours. So the catheter use is quite frequent, because you need every 6 hours to provide an antibiotic. This is something also that we need to be careful about. This patient probably could have been switched to oral therapy sooner. So at day 6, the patient was still on antibiotic because of pleural effusion. There was some doubts about was emphysema, blah, blah, blah. But nevertheless, the patient could have been switched to oral therapy probably on day 3. And therefore, we were having 3 days more than needed a catheter in that patient. Probably the patient with colonized Staph aureus, that 20% of the population is, and during the manipulation of the catheter, the skin, whatever, he developed an infection. So my lesson, the lesson that we have for that patient is that first, try to go to oral as soon as possible, and second, that day the catheter should be off.
Дуже дякую, пане професоре, за цю відповідь.
Thank you very much, Professor, for your answer. We already have no time, unfortunately, but people in the chat write a lot of thanks to you. I also would like to note that the lecture was very interesting. Thank you for joining us, and thank you all our partners from ICAP and CDC. I would like also to mention that the recording of today's webinar as well as all the others, will be available at the YouTube channel of the UPHC with lots of useful materials for healthcare workers. That's why get subscribed and follow the announcements, further announcements. Have a nice day and have peaceful skies.
Thank you very
Thank you very much.